That's good.
Now we're official.
Now we're official. Good. So, are there any announcements?
Chloe's joining us for the first time tonight. Not, I guess, officially.
Yes.
You've been on Zooms before, but she's here. Suzanne, who was with us part-time, got a full-time job, so she left to go join Fenway Health.
Very nice.
Yeah, so we're happy for her. And so now Chloe has stepped in to help us with kind of taking meeting minutes and running logistics for us.
Are you part-time?
No, I'm full-time
You're
staff here.
full-time staff,
Yes.
doing other things.
Yeah.
Doing other things.
Staying late.
Yeah, I know.
That's very
I already thanked her for that.
We appreciate it. Of course. That's great. All right, well, there are no members of the public who are present, so I suspect we don't have any public.
Not tonight.
Gee, you would think this would be a time that the public might be interested in commenting on a few things. That's
Not back to vacation yet.
yeah,
Maybe not.
That's probably the manning the barricades. All right, well, next item is to approve minutes. Approval of the minutes from the November meeting.
Yes,
All
I
in
agree.
favor? Good. Any opposed? Great, carries, we unanimously approved. Right, so we have a couple topics on here that do relate to some challenging federal actions that have implications for the health and well-being of the members of our community, the functioning of the department. So the first one would be federal vaccine policy update and discussion.
Yeah, so I wanted to put this on this and the next one for you all. You can speak to it as much or as little as you want. Obviously, we had some significant changes in the last couple of weeks on federal vaccine policy. In the meantime, the state has come out with its own recommendations. They're obviously working regionally across a number of state health departments to come up with some of these, essentially stick with the old policy because it's science-backed. And then AAP came out with a message the other day. So I just wanted to give you all space. If you had any perspective that you wanted to share with me, with the community, I'd love to hear it.
Well, there's an article in JAMA or editorial piece in JAMA today even about the fact that the states really, are controlling in this instance via mandates for school immunizations, et cetera. But that also is potentially the cutting edge if more states take a conservative approach and possibly then align to the CDC/Denmark standard versus and allow perhaps much more non-medical exemptions. And Massachusetts still has a religious exemption, even though I think I've lobbied amongst others to try to change that in the past, but New York and California maintain a prohibition on religious exemptions. If those states change.
Right?
Thank you, Richard Pan.
Thank you, Richard Pan.
Pushed that. One of our former fellows at the state legislature.
So, I mean, bottom line is unless there's some federal way to supersede the state's autonomy, and I think that'll be unlikely, let's hope, that at least I think this state is certainly very well enlightened, appropriate scientific standards. That's my 2 cents.
Well, there was an article today, I think in the Times, basically saying what just happened was just the first step. And that there's expectation that pretty much all the vaccines, they're going to move all the vaccines to sort of being individual choice at the federal level. And I think, one of the threats down the line is that would affect coverage, vaccine for children coverage, and I think they're also presumably going to try to affect the liability issues for manufacturers, which would again make it much more difficult for them to continue to produce it. I mean, so for now, I think you're right. The state has its guidelines, and the school requirements are the same.
But Hep B also is like a very long term until you see the impact, even though it's
Yes.
The rotavirus.
Well, as I'm saying,
Yeah.
some of the other ones, people
Rotavirus
hopefully
more
will see.
immediate and Hep A. I think that we've never had a situation before where the United States doesn't have a vaccine policy that is national. We now have little regional or statewide, or, it's really kind of horrible, but like blue state, red state vaccine schedules. I mean, you don't go online and just like, what is the schedule of England or something, United Kingdom, like the north of the United Kingdom, there's just one, like the Australian schedule or the Italian schedule. But in the United States now we have, right, effectively we're going to, starting immediately, we have different schedules.
But we were already decentralized on so many things too. I mean, like
But
COVID
this is-
policy.
for
I know,
sure.
But this is a
But
big
this
one,
is a
yeah.
big one, and I think for sure there will be states that will follow. Why wouldn't they? There will be states that follow the federal recommendations. And nobody is really talking about that, but I do think that's gonna have public health implications for all of us because we don't just stay in our little,
Well, there's this big outbreak of measles in South Carolina right now, which is.
Of course.
Surprisingly enough, spreading over to North Carolina.
and some of these, like, as you sure pointed out, like, Hep B is like a 20, 30 year disease before you see people ending up with liver cancer or like cirrhosis or whatever. But some of them, Hep A, meningitis, the other one is rota. You'll see things happening, but I think it's just more, there's a fragmentation of what we in the United States now have in terms of what recommendations and policies are being offered to us. It's really difficult to make sense of this.
You also said that in your practice, we have state guidelines that you're getting a lot of pushback.
I mean, I wouldn't say a lot, but I have had families say, well, we heard the news. We've heard the news that is that vaccine still going to be covered and is that vaccine still recommended? I think it's gonna have implications for us too, but I mean, more like public health in the United States. We're gonna have a lot more vaccine preventable diseases that are circulating that didn't used to.
It's already happened.
Of course, the measles is a good example.
I think it's really unpredictable what will happen in the next half year or year. Florida, of course, has been entertaining this idea of changing school policies around vaccination. I don't know while they are making that happen at this point. And I actually have not heard that the red states are necessarily picking up in the federal guidelines yet, but they may. I mean, I think most of the health departments don't want to do that. Okay, but when you get to the legislature, it may, and legislatures might decide to enforce the federal guidelines. I think the other two or three things, one is that the announcement last week was very clear that all these will still be available, they will still be paid for. So they were not at that point changing vaccines for children or other financing mechanisms so that people should have access to them, at least. That's a step that could change under this administration, for sure. But I think we're hearing nationally that, like you are, that lots of people are spending more time talking about vaccines with patients, trying to sort of help them make some appropriate decisions, lots more questioning than they used to be. And even some vaccine refusal. So that's happening. I don't know where it's going to go either.
I think it's like vaccine apprehension because people hear from the government that these vaccines are going away. They're not needed anymore. And so now people say like, well, you're telling me that rotavirus is still a good vaccine, but government is saying we don't need that. So
yeah.
I think people are sort of unsure. There's more uncertainty. I think these are people that perhaps weren't normally going to be vaccine skeptics or vaccine refusers, but now they're vaccine questioning something or vaccine worried, the vaccine unsure. It's a new group.
In parallel to the vaccine issue, so John, in the Boston Globe, they were talking today about how in the community health center environment, folks who are eligible sort of for the modified mass health as undocumented are unfortunately not appearing at all the same numbers that they had in the past. And I guess the question is, from the Brookline Health Department standpoint, you know, are there ways to reach out and try to at least like have a sort of a pull into the department for vaccinations at minimum, you know, so that a standard of care can be achieved for folks. Again, I'm not sure if the Office of DEI or so that showed us the documentation they've got for, you know, how you can protect yourself legally. But the question is, can we sort of use those same channels to make sure that people know that there's a safe place to get their vaccines, even if they fear showing up in a federal health center?
That's a great point.
Are there any issues about your sharing, being required to share data about who gets vaccines with outside bodies?
Not yet, but there have been other departments in town government where those requirements keep adding on new requirements about data and how to share and what needs to be shared. The state's been a good partner in helping push back on some of this, but it sort of remains to be seen how far that's gonna go. But a lot of concern on what gets shared and what happens with that data when it gets shared.
But this whole idea of setting up the revolving fund for our vaccines, so we do bill for it.
We do bill for it, we do get reimbursed, and then that money goes back into the vaccine program. And Kat, I should have said this in the announcement, Kat's back, which is excellent.
Oh, yeah.
So she and I will be sitting down over the next couple of weeks. We did have a brief conversation before she went on leave. I wanted her as a thought partner, thinking about whether or not it made sense to expand our vaccine program. I would like us to, but I don't want to do that without her support. So she and I are going to sit down and think about what does that look like if we were to expand beyond. I mean, predominantly it's VFC and then the flu in the fall.
Right.
But I'd like to do more, and there are departments that have a much more robust vaccine program, and use that revolving account to maybe hire per diems to expand even further. So we're going to start digging into that and thinking about what a new model might look like. But I know for sure among staff, we've had conversations about the data we collect and how we protect it and what we may or may not be obligated to share depending on funding sources. So.
Right, if they're Medicaid, we're billing Medicaid, that
Then,
information.
yeah, there's
that's, used.
trail there.
Yeah.
At least the blessing is it's after the fact. Their demographics, I understand, are already released to ICE and to other organizations at this point, basic demographics, but if someone has an encounter here,
Yes.
you're only selling the information after the fact. So.
Yeah, and it's only information that they got vaccines. Why did you, we also talked, John and I, about education, things we should be doing in town. And I guess we're gonna do a podcast with friends. Did you see that?
I think it's Wednesday morning at 8 a.m.
So
Yeah.
maybe we-
I was just saying, at first it sounded like it was in the afternoon, but now it was like it's 8 a.m. on Wednesday.
Great.
You're doing it?
No, you.
I know, but you said we, so I was like, are you part of it?
No, I killed.
The royal we.
I made the connection. I made the match. That was all.
But yes, no, I shall be doing some talking about it. So maybe that's useful. And then it sounds like maybe Darlene will upload it somewhere to BIG. I don't know what is BIG. BIG is.
Brookline
Uh,
Interactive
okay.
Group or something.
Okay, it's gonna go to Brookline
Closer.
Interactive.
Great.
Maybe Facebook.
Oh yeah, Darlene will make sure it's all over the social channels.
Good.
She's so good.
She's very good.
She's really knows how to.
Is there any other, or is that the best?
I think it's a starting point for us.
Yeah.
And I appreciate you stepping up so quickly. Like this all came together in the
Oh my
last
goodness,
few
I
days.
really care about this. Yeah, like when this came out on Monday, I was like, I can't believe it. What is going on? You know, when I read it, and then in my office, we've been really talking about nobody. I feel like unless you're a pediatrician, I don't know, or deeply involved in public health, people are like, what?
Yeah.
We're in Massachusetts. Everything is the same. It's like, but it is. Like the environment has really changed on us. So yeah, I think we all understand that these are seismic changes.
Well,
But-
good,
Yeah.
I'm thrilled that you're doing that,
Yeah.
and I think we should be expanding, we should be filling gaps, and also reminding people that the school is the same.
In some countries, they do vaccinations in the schools. Do we have any mechanism in Brookline or in the state to like change that setup?
Interesting.
So the school nurses, I will just say like my little involvement here is that the school nurses in Brookline are pretty awesome, but then they send them here. If they don't have like a
Right, we would
pediatrician.
need a different program,
It
but
would-
like
it
there
would
are
be a
countries
different-
where
Yes.
like kids in September get everybody who
It
doesn't have
sounds
it,
good,
just gets
but-
the MMR, they don't need, the parents need to have insurance or go to
No.
a pediatrician or make an appointment, it just, if you're absent that day, it's a problem, but the
It's so
coverage
not
is-
happening. It would be a good idea, but no, that doesn't.
It's happened before. I mean, when I was in high
With
school,
vaccine or-
dating myself, mid-90s, I don't know what new vaccine came out. If it was
I think
Hep B
it might
or,
have been like measles boosters, because the 90s there were measles boosters, no?
or meningococcal maybe.
Maybe.
I don't know, but it was a
Yeah.
mass vaccine program and everybody in our high school got the whole,
I believe
it was 2 or 3 shots, yeah.
And it saves the parents, you know, it saves, there's a lot of
Yes.
advantages to that
Yes.
system, except for, you know, my kid doesn't go to school that day, they can just, but
I mean, we can have that
Just-
conversation with them for sure. They are good partners. And right now it works in the opposite where they just refer over to us,
Yes.
which creates barriers because you're having to schedule with Kat, who's wonderful, but it's yet another step for them rather than having them just do it at school.
But vaccines are like, I want to be on board with this because I like the idea. And some schools, like some high schools, will have sort of like almost like a health clinic that kids can stop into.
Yeah.
But vaccines are a tricky sort of thing, and they need to be kept at a certain temperature. It's not like you can be like a school that's doing like an occasional polio booster or something.
Right.
Like you need to really.
it just something to think about when
Yeah.
you're
Yes.
thinking about like big
Yes.
picture, maybe long term, it's something
They don't have, I think Brookline Public Schools, I think primarily has families who have physicians, I think. Because it doesn't seem like we have that many kids who are coming here. So it's useful, I think school clinics are useful for people that just don't have access to like a clinic or a physician or whatever place to get vaccines, but it seems like, it works here when they come, but yes, it is an obstacle.
And it could be as simple as just switching the model a little and maybe Kat does office hours at the individual schools.
Yeah, comes in and they tell her like, these are
On a
the kids,
specific
and she
date or-
goes through and is like, this is what I need, and she brings a little cooler with her.
And even like kids who come from other countries and then they can't start school because they haven't
Yes.
gotten certain things on board, maybe they could just do it at the school or through.
I mean, they do prevent them from starting. It is a
Yeah.
big carrot,
Which is good,
you
but
know, like, school, you can start, but you need to get vaccines first. Come here.
And they get here quickly. I mean,
Oh, yeah.
they make it a priority, which is good.
Yeah.
But I'm open to different models for sure. Yeah. I mean, I think for us, I think the challenges are exactly what you all described. I think messaging for families is a big one. And just being part of, and that's why the podcast kind of came together was we need to start messaging on this now. We need to be part of the chorus of science and medicine that's saying this is reasonable and good and good for your health. And I think it's getting more confusing for parents. And I think it's normal for parents to just question. And when you don't have good partners at the federal level, it just complicates things
Yeah.
for everybody. And then I think there's the whole challenge of the burden on the healthcare system.
Yeah.
Right? We're at a time when we're talking about affordability and we're changing how we fund, the federal government's funding healthcare, whether or not it's gonna fund certain groups. And now you're on top of that, adding a layer of these preventable diseases that's just gonna put an additional burden on hospitals and public health because we're the ones that investigate all the outbreaks.
I think Jeremy Faust had the line, he said something you can say to parents, and maybe this could be helpful in the social media, is the politics have changed, but the science hasn't changed. So to push it back, so like, you know, there's no new research, there's no new guidelines, the AP is saying the exact same thing, this is a political thing, but here as the public health department, as your doctor, the science hasn't changed.
Science definitely has not changed, no new studies.
If anything, the science continues to reaffirm
Yeah.
and provide additional support. Yeah, well, thank you all. We'll keep you updated on our efforts moving forward. I'm hopeful that Kat and I will come up with a new model. And it may be something that we have to grow slowly over time. We're gonna have to build up the revolving account in order to do some of the things that we would like to do.
Yeah, what would you like to do? Is that something you can talk about like now, or do you want to add like vaccines for like shingles or pneumococcal for adults? Like, what are your thoughts? What area?
If there was a magic wand, it would be, we would be a one-stop shop and we would be people's primary source for vaccines. Beyond their physicians, right?
Yeah, but like those are vaccines that like a lot of people need and maybe don't get, and so you could have like shingles fair or something, or like the Pneumovax fair at like the senior center.
Yeah.
All right, I get it. So you really are, you have broad plans.
I mean, I would, yeah, but again, I want to be realistic and recognize that Kat is one public health nurse and she's got a lot of responsibilities. And so, maybe we can partner with, and again, we have MRC. And MRC is the kind of the manpower, the person power behind our flu clinics. Can we activate them more often? But we just have to be smart and strategic about it and make sure we do it in a way that works.
This is so interesting because, in the old days or in the South, for example, the only place people got their vaccines was in public health, public health. The data actually showed that wasn't correct, right? That immunization places where it's required to go to, where you have your doctor, we have immunization rates were. On the other hand, now, people, I get my shots at Osco. It's convenient. I go grocery shopping and get 10% off on everything I buy. And, and it's great. I can just walk right in and get everything done and stuff like that. So that old framework of what didn't work or wasn't as good is different now. So it's interesting. I don't have an answer on it, but convenience.
That and too, things like shingles and Pneumovax or so for the Medicare population, they have multiple outlets. They have the insurance coverage.
Right.
I still think that the child and adolescents or so who unfortunately might be in the gap or their parents might be in a socioeconomic status that makes it more challenging.
Yes.
It should probably be the main focus of the department right now. Great if we could take it all in one, but then we might be competing with CVS down the street.
It should be though.
I don't know.
That's not our primary. Our primary focus isn't making money, but they're in the market for a reason. And I just think as departments need to think strategically about it, are there opportunities for generating revenue that allows us to protect staff and keep them on board and keep them doing the good work? Otherwise, we lose a big. Public health nursing is one of the most critical. Other than our inspectional services, those are kind of the two primary drivers of local public health in Massachusetts.
As you say, if they're here, you want to capture them, right? And give them the shot right away rather than lose them and say, well, we'll refer you to someplace else and hope to get there.
I think people often don't get vaccines because it's just not convenient. So the Department of Public Health has that option. It's like, it's not that Osco and CVS are not convenient. You have to schedule online. If there was something where, but it's hard to bill them. If there's a flu clinic, somebody has to be getting everybody's insurance information. I'm gonna be honest, it's a headache. But that way you get people who are like, oh, I'm needing to do it. I just haven't had the time. That's when you ask, I guess there was some studies about why didn't you get the flu vaccine? The big one is just not convenient.
And we've seen that. I think about some of the places where Sarah and Kat have planned flu clinics over the past couple of years, like after school at the Baker, you get all of the families showing up because they're already over there. This past year, we did one at I think it was the high school. I say we, I was not there, to be clear. I want to give credit to where it's due to the staff that were there, but we saw an uptick because it was at the same time as basketball tryouts for the travel program. So I think, thinking about convenience and catching people where they are, I'm having a meeting. This is a bit of an aside, but I think it's connected. So I'm having a meeting with the directors for rec and the senior center because there's a lot of opportunity there for the three of our departments to be working collaboratively. Where populations are coming in and already doing programming.
Yeah.
If we can be smart and strategic about it and plan around it, we can be getting people that are already there and coordinating. So. And library is another one, but obviously they're in transition right now, but we will definitely involve them forward.
Well, good. I think this is good and productive conversation about the department as well as the national issues. The next item on there, I think to some extent, I'd like to probably punt this in detail to another meeting, but another public health related issue that came up this past week was the release of new dietary guidelines. I haven't scrutinized them carefully. My read on them in general is that they're a mixed bag, that they include some things that are not bad. They promote breastfeeding, they promote no added sugars, they promote not eating ultra processed foods. Well, I think people are supportive of that. They encourage full fat dairy, they encourage the consumption of red meat, cooking with beef tallow.
There's a huge increase in market demand for tallow.
Whatever the heck that is, but anyway.
Bad for vegetarians.
Yeah.
But they didn't change the proportion of saturated and unsaturated fat you're supposed to have, so how you can eat beef tallow without red meat without changing that is not
The
clear.
whole pyramid doesn't, it's not clear if it's a pyramid or
It's not
a representative or like.
And they removed the alcohol, the
Yeah.
recommendations for limits on alcohol that they come up with.
Yes.
So, again, I don't, Jim and I emailed briefly, I mean, we certainly know people who are expert in dietary guidelines. Be happy to see if we can invite them to talk to us. You know, part of the question I wanted to raise it here is, again, should the department be doing anything locally?
Has the state, have we heard anything at the state level?
Not yet.
No.
I'm saying I feel that people like, you know, are not that interested in these dietary recommendations because I don't really think people were following the prior dietary recommendations, the My Plate. Remember the My Plate? That's what it was called. Like that's the name of the old dietary
Mhm.
recommendations. Like everyone's like, what are you doing? But it hasn't been a pyramid for like a decade or more. But no, but I mean like because we don't, nobody's really.
But it influences school meals.
It does. It does.
And the
This is
picture of the
weird
plate
and
that's half fruits
Yes.
and vegetables, that's
And then
nice.
like it's like the little colored
I
sort of.
think of it, I always think 5 fruits and vegetables a day.
Yes,
getting my
actually,
5
that
fruits, you know,
was-
that's-
that is a
sticks in your brain.
I guess that I think of these as, yeah, I hadn't really thought that it's influencing school lunches. I don't think of them as influential as like the vaccine guidelines.
They are, it's just
You're
in a
probably right.
different, it's a different venue than we.
Yeah.
I don't know. I think they will have a really impact at that level. It's interesting how they affect that. I meant to bring some prunables to share. I forgot to.
Cooked in beef tallow.
I mean, don't you
Yeah.
remember when Reagan said that, you know, ketchup was a vegetable and stuff like that? You know, I remember that. I'm old enough, but anyway, that was, you know.
No, that was Reagan. I thought that was.
So anyhow, maybe we'll
Yeah,
have,
we'll have some.
we'll have somebody come and talk to us, I think. Mary, did this come up in your work? I mean, you were so connected to all this at WIC. Mary, are you there? Maybe she's doing other things, so.
Or she can hear it at that moment.
Yeah, she ran the WIC program.
Yeah,
I mean, I know that
She-
Brookline's public school system, Ezra, he just graduated last year, a high school student who I worked with a bunch of town meeting, also worked a lot on their school committee sustainability policy and try to get meatless Mondays and
Yeah.
try to have like 50% plant-based foods, and so that's like a target for the Brooklyn Public School, so they're really looking at it there, so I would be very upset if this.
And there's nothing on plant-based foods in the new guidelines.
Right, so I
No
guess it doesn't go either way,
recommendation.
but I don't think they're serving much beef tallow. but
Yeah. All right, so to be, I think to be continued.
Yeah.
I'd like to see if we, it'd be interesting actually to get some from the schools.
Sasha Palmer's.
Yeah, I was gonna say, school nutrition has been wonderful partners. And I think there's overlap because we're working on food insecurity with them as well. They're one of the partners on addressing food insecurity, so.
Yeah, there's kind of a funny thing there too, I don't know if this is relevant, but like food waste also, because for the first time my daughter's a freshman in high school, and she says that if you get a free meal, you have to take the fruit and the milk, like that's part of the deal. But if she just wants a single item, then then she has to pay out of pot, like it's not included, what's it called, a la carte?
Yeah.
And so then she's getting, so she can either throw things away or get charged, like those are her choices.
There's no way for us, as the
I
school,
don't
work
know, I
on something
understand,
that
like, you're supposed to have
processes.
a balance, if it's covered by the school meal policy, it has to be balanced in a certain way.
I was just wondering whether we do anything with food waste, whether
I don't know,
a bunch of programs that
composting, I don't know.
either
compost.
composting or providing it to other,
Pass it
that's
on,
on
yeah.
your plate,
Yeah.
but if it's
Unopened,
rancid,
yeah.
if it's unopened, there could be.
If there's a place to deposit
Yeah,
it,
so-
then it could be then delivered to the food bank, that's a great idea.
That is a statewide problem. So that is something to do with the funding sources in this program that is
Yeah, right.
causing this, because I've heard this in another number of other communities. Yeah.
It's great that Massachusetts continued the free school lunches after the pandemic.
And breakfast.
Yeah.
All right, let's put that to another session. So moving to another topic of homelessness.
Yeah.
Turn one up. We brought that up here, I think in the past, we discussed it, we highlighted that the Harvard School of Public Health actually has a whole homelessness program, and we spoke at the local public health conference.
That's right.
And encourage public health folks to be more active, so we can do with the school.
So I immediately said I need to get a hold of Dr. Howard Koch because he has all the answers. A little bit harder to get a hold of than you'd imagine, but thankfully Charlie has some connections to that program and got us connected. So we had an initial conversation. Eliza Houston and I had an initial conversation with Jeff Olivet, who's a senior advisor over there at the Initiative on Health and Homelessness. He's half-time in DC, half-time at Harvard, but has worked he's been a street worker and he's worked all the way up to the federal government. So he's seen the gamut of what is possible for addressing homelessness. So we just had an initial 30-minute call. We kind of laid out kind of what is happening on the ground for us in Brookline and in local public health. And he gave us some initial thoughts, said he's happy to stay on as a thought partner and connect us with others in the department. And he has already done that. So he's connected us to staff at the Department of Mental Health in the state. And I got an email today connecting us with somebody in Boston. So yeah, so it's very much in the planning stages, but it was just good to finally connect because right now what we have is somewhere in the neighborhood of 5 to 10 homeless people living in town. And residents want us to do something, rightfully so. And they just expect that we can solve the problem. And I wish that we could very easily, but we cannot because people have autonomy and rights. And so we spend a lot of time on the phone talking to residents about that. So we have two roles here.
Yeah.
We have an enforcement role when it comes to hoarding, which we've had some examples of that recently in Brookline, where the piles of people's property grows and grows. And then the other piece, which I think is for me the more important piece and where I want to spend our time and effort, is on the humanitarian piece and supporting these people and getting them into housing and starting to work on some of the really complicated issues that come with it. And so it was great. It was, didn't get very far, but a starting point, which is more than we had a couple of months ago. And we have partners in town too. I want to give credit where it's due. We did have a homeless task force that was running for many years. Casey Hatchett, who's the deputy superintendent on the patrol side, she just got that promotion, was the one who started that program initially. She's had a number of roles over the years, and so she hasn't been as heavily involved, but now that she's in leadership, she said she'd be happy to step back in and help us make the right connections on the police side, because they do a lot of work in this area. The community policing division does a tremendous amount of work and knows all of these people and has built relationships with these people and tries to get them services. We have some human service staff in the police department that do this work as well. We now have human service staff on the public health side. So that's sort of where we're at. It's very early on. We will look to see if there are any funding opportunities for us to expand this work. And then in the meantime, we'll also be figuring out what programming we can add that isn't already available.
Does the town have any emergency shelter facility?
Not that I'm aware of.
Yeah.
I think we rely on others. Yeah. Yeah, and so because the police do the checks on individuals, they're the ones that have that resource guide and share that out So what has happened in the past, is we will get the calls and we say, you need to speak to the police department. This was before Eliza got here. You need to speak to the police department. We don't have any behavioral health staff. We don't have any street staff that do this work. These people are residents, they have a right to property, and so we are not just gonna step in and take away everything because you don't feel that they should have it. And that doesn't get us very far. Right? And I understand the frustrations on all sides of this issue. It's very complicated. I just hate to send people to different, I think what happened was residents got frustrated because they would go to the police department. Police department would say, when it comes to the trash, you need to talk to public health, trash in quotes. You need to talk to public health. We'd have to get DPW involved if and when. So it was very, very frustrating, I think, for everybody. And I don't want to waste people's time, and I don't want staff spinning their wheels. I'd rather, let's figure out some real solutions. So
How are you getting, or anyone getting complaints from the public?
we were getting, Chloe, you were answering a lot of the phones. I don't mean to put you on the
Yeah.
spot. I mean, we got a lot of calls over the spring and summer.
Yes,
There
I
were,
would say there was a period of time where it was 2 a week, probably.
there you go. And then there were some emails in addition to that, and then
And
I think-
frequent flyers too, people would call over and over again because they were getting bounced around and.
yeah. And that drives me. I don't want to bounce people around.
Yeah.
Like, that's wasting staff time, it's wasting the residents' time. The residents are just trying to help this person. And we got a lot of people coming up to us at Brookline Day and asking specifically. And so I brought them over. I said, let's talk to Chaz, the chief of police is here. Let's get everybody in the same space. And we were all in the same message. And I don't think that was, it didn't sit well with residents, but I think hopefully at the end of the day understood that we were trying, but we were limited in what our response could be. So now that Eliza's on board, we have a little bit more bandwidth as a department to work on this issue. And she's been great. And I want to be respectful of people's privacy, but she's worked on some specific cases and gotten to some level of resolution in at least one of those cases. So it's been incredibly helpful to have someone with her background on the team to be able to address this. Because before, it was Chloe and Wendy answering these calls and wanting to be helpful, and I think feeling a little bit helpless that there wasn't anything that public health could do, other than refer people to other resources.
I think having the interagency work group, I think is gonna be critical. So that police department and DPW and us preaching the same thing, working together, have a coherent plan, and then to the extent we're getting guidance from folks at Harvard.
Yeah.
That's true. It's like real progress. Going back, by the way, to my hobby horse of housing, I just saw a phenomenal video on does building luxury housing for that. I'll share it around this about a half hour video. The answer is yes, of course, because expanding housing for all this man. But it's a great, very elementary, clear to share. So not useful for individual cases and case management.
Prefer to see it.
I'll send it around. Just be worried. Terrific. That's great progress. Did you find out whether we do participate in the count or not? Public.
I have not found anyone that participates yet, so my gut says no, but I don't have a definitive answer on that.
We should. It sounds like the police think we, had 5 to 10 folks.
Yeah, I think at this point, the count is those that they're already engaging with, and maybe some of those that they're on the streets 24/7,
Yeah.
right? So I remember, we had some materials, personal property in the back of the building a few weeks ago that I came across, and I said, oh, this is interesting. I hadn't seen this before. And so there was a detail going across the street, so I just asked the officer, I said, hey, did you see anybody? Because there was nobody there with it. And he said, oh yeah, we know who that is. Because of course they do, right? They see everybody and everything, and so they had a really good sense of who it was, whether or not they were a quote unquote regular or not.
I was gonna say, I have observed that, Brookline home on house people sometimes live in Boston because I spend some time riding my bike. And I've seen people that sometimes I see in front of Brookline Booksmith, sleeping. Also sleeping near Boston University. So, you know, just because they're like here, they may be a little bit more mobile.
Yeah.
So I do think it would be valuable to get connected to Boston. It's not like we're an island. You know, they might just go to someplace else because it's, nobody's bothering you as much that day, so you go there or whatever, you find a good place to use a bathroom or something. Yeah, it was the exact person, I was like, oh, you're here now, you know, in my mind.
And there's the encampment right over the bridge.
No, that encampment has been,
No, it's,
maybe we're talking about different ones, but
yeah, there was one on the Cambridge side.
there
but
was
now
a
there's
big
on
one.
Boston.
There is that one on the Boston side. There was like a whole little,
The whole village.
yes, with like
Or I won't go I won't go here, I won't go.
so in any event, I do think like that they're not just like our unhoused, because I think they're going to Cambridge or Boston.
Yeah. And Boston's changing how it responds. We've seen that with Mass and Cass. There's an article in the Globe last week or the week before. There was a church group that was coming up on a regular basis to Mass and Cass to provide support and resources. And the article is all about how this group is now being tailed by the police department continuously and told to move. And essentially what it comes down to is they're not a registered agency with the city. And so, you know, although they're doing good, the city really wants to direct people to buildings where the resources are to try to get these people into the supports that they already have, which I get. But all of these things change the dynamics on the ground, and I think it means that these transient populations then bounce around. And so I just want to make sure we're prepared in case additional residents show up.
Yeah.
So I will keep you all posted as we make progress, but there are more meetings and more discussions happening.
Great, thanks for doing that.
Yes.
That's true. Tell us about the vending machines.
Yes.
It's really cool.
Share my screen here. So this project has been, I think we need to take a half a step back. So we have Project CAN, which is citizens accessing Narcan, which EJ had started with Sarah and Darlene. So we had emergency preparedness and community health. Kat has picked up that program and kept it going with Darlene, and want to say on an annual basis, we are distributing somewhere in the neighborhood of 400 to 600 doses a year.
Marvelous.
And we've built some great relationships with other, individuals that are doing programming with vulnerable populations. We are often not always getting the Narcan free from DPH. So there's no cost to us as a department, and it's a great opportunity to work with individuals and at the end of the day, reduce the potential of people dying from overdoses. So it's been a great program. So the state has matching grant programs. So the RISE grant has been available for I think the last 2 years now. We had applied. Darlene saw an opportunity. I think we were both inspired by some other communities that have public health vending machines. And so we applied, we received the funding. We have a couple more months now to get this program up and running. So we have found a vendor. We have identified locations. We've talked to a number of internal and external partners on where these might be located. We've run into some barriers. And so we're here tonight to present kind of where we're at and get your feedback, and then hopefully ask for your support tonight. And then tomorrow I will be presenting to the select board and asking the same thing of them.
So there's funds that come through a grant that the state has.
Yes, so it's opioid settlement funds. It's like a 60-40 split. The state holds onto a bunch of the money, but then redistributes it through all these other programs. And one of them is this matching grant. So we are using 25,000 of our opioid settlement, and the state has matched with 25. And
so it's all opioid settlement.
It's
some
all
of it is ours, and some of it is the state's.
Yeah.
Okay.
Yeah. I think wherever we can find opportunity and there's good programming to do, we love to tap into state funds and bring more programming to
And it's highly appropriate for opioid settlement. That's what it's supposed to be used.
Exactly. Right. I will say this is my first time using Canva as a presentation platform, so this is gonna be fun for everybody.
Opposed to PowerPoint?
Yeah, I'm such an old school PowerPoint guy.
Use Yelp graphics.
So this is what Darlene has coined the Project Can Connect program. So that's taking the existing program and now making it a 24/7 vending machine platform. We will be leasing these vending machines. We'll talk about the vendor in a second. They'll manage all of it for us, which is great. It means that they will always be stocked with whatever we decide to put in them as far as public health essentials. And we're using an evidence-based program that has already been implemented in, there's Somerville, Boston, North Adams, and there's one other community. I think it's at one of the FAQ slides at the end. And so we just thought this was a really exciting opportunity to kind of expand the work that we're already doing. And also, you know, the funding source and kind of the starting point for us was harm reduction, but it's really an opportunity to provide public health resources to everyone 24/7. And I'm already getting ahead of myself. So naloxone's the primary object that will be in the vending machines, but we'll also be providing hygiene kits when we get them, the COVID test kits and or maybe some flu test kits in the future. Some of those are combos now, which is nice. And additional resources that become available. You know, a lot of this we're already doing. So it's really about taking what we're doing, pulling the staff out of it, and just having the machines available. And you know, libraries have been wonderful partners. Some of the religious organizations were wonderful partners early on when we had that mass distribution that we were doing. So to be able to just point people to a resource that exists on the ground and let them get it when they need it, honestly, it reduces exposure, especially as we think about COVID. We have air filters that we run out in the hallway, but you know, nothing's perfect. And it reduces stigma even further, or reduces the barriers even further. So we're really excited about this program. Somerville has been piloting it. I have not had a chance to talk to them to see how it's going, but those are live. They have one at the library and one at their food pantry. A lot of these items that we're planning to introduce are items that Somerville and Boston have introduced in their programs. So like I said, naloxone, the fentanyl and xylazine test strips, Datera drug disposal bags, which we give out now at the front desk. We will be partnering them with Sharps Containers, which is a very popular program here in Brookline.
What do you do with drug disposal bags?
So for us, there's no place right now in town where you can dispose of medications. I think we send people to CVS, right? So it used to be that we had one at the police department. We do not right now. So kind of for the municipal side, one of the steps we've taken is receive these through a grant, these Terra disposal bags. So there's a substance in them, you pour the medication, you pour water, you mix it, it makes the drugs inert. And then you can just throw it away, seal it up and throw it away.
Okay.
So sort of a stopgap. Yeah. I think eventually we'd love to have our own kind of drug disposal, but the antigen test kits we've had in the past, we hope to get them again in the future. Personal hygiene products are things that are already kind of distributed town-wide in a lot of municipal buildings. The safer sex kits, wound care, Darlene's looking at some winter weather protection. So some of this will be seasonal, whether it's winter hats or gloves or socks or whatever.
And you can purchase all, I mean, some of the stuff like the naloxone that's free from the state, but the other stuff, do we buy it?
So that's budgeted as part of the grant to start with. And then and so what we'll do is we will budget as much of the full amount as we can. So it's the 2 vending machines and all the materials that we plan to put in them. And then we'll have to kind of plan in future years. I think what we need to do is get the pilot up and running and see which products end up getting pulled out of the vending machines, and that will really inform how we budget for this moving forward. So that on the bottom right there is an example of one of their kiosks. I think I have the Somerville kiosk in a few slides. So it's ADA compliant. It's got, I think, over 21 languages as part of the interface. So we're covered there. It's available, like I've said, multiple times now, 24/7. It's weatherproof, which that's been one of the challenges for us. So we have some, including one in the public health building, boxes where people can get naloxone when we are closed or if there's an emergency. We wanted to do that out in some of the more public spaces, but we are worried about them freezing in the winter or cooking in the summer. And so having these 2 vending machines, they're temperature controlled, will mean that the naloxone's ready to go. Yeah.
Good idea.
There's no glass, so there's we'll have a list of all the items, but there's nothing, there's no screen there for people to actually see the items until they come out of the vending machine. We asked them, we've had a couple meetings with them, we asked them about vandalism, they said there hasn't been much. If there is, they manage it, so it's on them to, yeah. The company handles everything, so they do the delivery, they do the configuration, they do all of the restocking and maintenance, they track it, they know how much they put in, they know how much is coming out, and because they have contracts in other communities, there are.
This is a for-profit company?
This is a for-profit company, yeah, so this is, I think, a new model for them. And then we have the opportunity to do some age restriction for sensitive items, if and where we find it appropriate.
Any thoughts about that?
So what I will share is, it is as simple as them entering their date of birth, which is not the strongest barrier, but it is a barrier. I will say, I think, I expect this will be part of the conversation tomorrow night. And I would say, when it comes to the products that we are supplying in here, I want kids to have them, if they want them.
If they need them.
Right?
Yeah, what's the,
If it's a COVID test kit, if it's condoms, if it's xylazine, whatever the test strips are, I mean, if they feel they need them, then they probably should have them, and they might have an opportunity to save a life down the road.
Is there anything that's misusable?
I think one of the things I've heard that might be of concern is making the naloxone available, but I think once they understand there's no side effects there, that they'll be okay with that, but I don't know for sure. So it's gonna be available to all community members. Like I said, some of the items may have a restriction, which just requires them to enter their date of birth. We'll do a lot of, I expect Darlene's already thinking about this, a lot of education and outreach about that the vending machines exist, what's in them, how to use them. We'll do some workshops. We'll have to do a lot of engagement with staff, because I'm sure they're gonna get a lot of questions. We'll do videos and messaging. We'll have a webpage. And ultimately what this comes down to is, and this is a priority for us, it was in the chip, is centering health equity, making sure that everybody has access to what they need to thrive and live healthier lives in our community. And I should have said at the top, and I didn't, we are branding these, I've said a lot of different things of, Brookline Project Can Connect is the program.
Yeah.
We are branding the vending machines, the Be Well health stations. So Be Well is our coalition. So it's an opportunity for us. These vending machines will be kind of our first opportunity to start branding the coalition, the Wellness Coalition. We'll also be putting some messaging on. We will, as part of it, we get to put a skin on these machines. So we get complete control about the images that are on there, the phone numbers and all that. So like Eliza's program will be on there. So we'll make sure that Find Help resources and the QR code and URL are there for people who need additional supports.
Tom, what about sustainability?
Well, I think we don't know going in who will use what resources. So it's a pilot, and it could be that it's a great program, but it's in the wrong spot, and we won't know that until we get it on the ground, and we don't know what people are gonna look to use out of those vending machines. And so I think we're gonna learn a lot in year one, I think, about how much it's going to cost to sustain. Well, the cost of the vending machines themselves, the lease, is something we can certainly absorb through the opioid settlement funds. I'd like to think it's something that the town would support as part of our contracted services. We're obviously in the midst of some budget conversations as a town, so that will kind of inform what I'm allowed to do or what I can afford to do as a department head. But it is a small portion of our budget, and I think this is a good use of opioid settlement funds. We're doing a lot of good work already with our substance use prevention team. And so I think this is the other side of that, which is starting to get more into the intervention and treatment and support side for those that are, you know, either in recovery or actively using.
This really does sound great. The opioid settlement funds will last how long?
Yeah, it's sort of a moving target. Right now, because there's a lot of staff on there, I think we drain it down in about a decade. But there are additional settlements to come in. Those staff are writing grants to try to sustain their own positions. I'd like to think that over the next decade, I can convince the town and the town administrator and the select board to maybe potentially move some of those positions onto the town budget, but these are all, you know, dynamics we're gonna have to work through. Yeah.
And then just to, so it's a pilot, that
Mhm.
presumably means there's an evaluation. So what are the metrics? How will we know if this is quote successful?
Right. I think it's a combination of the vending machines themselves allow for a little bit of data collection. So we don't ask for any personal health information, but I think there are configurations that would allow us to get maybe something like age and certain other demographics that people are willing to share. We'll certainly have, you know, from a process standpoint, we'll know what's coming out of the machines. And then I think we're gonna have to do some community surveying and some additional focus groups to see who's using, what they're using, are they in the right
You get data from the
location?
machines too?
Yeah, some, but not a ton.
We won't know about the users, but the time of day, the frequency,
Yes.
what's being taken, like that would be
Yes.
interesting to what empties out.
Right.
What's not getting ordered.
Like if we learn that they're really only being, so, and we're not quite through the whole presentation, so I think it's important just to.
Sorry.
No, these are all good questions, but,
I
okay.
really do like the way that you made this like move and everything. It's like such a cool
This was
presentation.
Darlene. Are you surprised?
Oh, it's Darlene. Okay, well,
And-
tell her.
and
You know, is it stuck or?
I think it might be stuck.
But it looked like.
Oh,
you're
I
at
went
the
too
end.
far. I went too far. I
Yeah.
don't know how I skipped ahead.
Oh, yeah.
I apologize. I really did get too far. How I managed that. Okay, so the two locations that were selected, so we, you know, Darlene and I went back and forth for months on this. She did a lot of work, tried to do some focus groups with those in recovery and those actively using. Really challenging to get a hold of some of those populations. We do know that some of our vulnerable populations are using our municipal buildings on a regular basis. Our libraries being one of those locations. So we said this is a pilot. We need to be in high traffic areas. They need to be accessible. And so libraries were kind of it was MBTA. And then it was, you know, when we started thinking locations, we were thinking Coolidge Corner and the Village, Brookline Village, because those are high traffic areas. MBTA would have taken a lot more logistical work. And I think they're working on their own vending machine program. So we said, all right, that's out. And so libraries, when we decided we needed to be near buildings because we couldn't figure out or we couldn't afford the logistics of pulling electricity off of a power line and, you know, siting a location along a public way, we said, great, let's focus on municipal buildings in those two areas. And libraries were just kind of one of the obvious choices. It was either town hall, the libraries, public health building. And so we had some conversations with staff. Staff at the library are really excited, at least among the ones that we talked to. They, again, have been partners in the past with COVID distribution and other public health programs. They're obviously in the midst of a transition. So we had some conversations with the interim director. They were supportive. I'm waiting for the new director to get in so we can have that conversation, but they would be sited outside of the building, near the doorways. And that way they're accessible 24/7. And the reason, again, high foot traffic areas where vulnerable people are already, you know, we send people to the libraries for heating and cooling emergencies because they're open more hours than we are, and they're open on weekends. And I think people feel comfortable going there and they see it as a safe haven. And so to have this there and a set of resources that librarians are already pointing people in the direction of, I think just makes everybody's life a little bit easier and hopefully provides support to people.
What's the hygiene? What's the hygiene, like a toothbrush and soap or?
Yeah, there are some kits that already exist that Darlene was looking at, and then we might build our own. I'll have to look it up.
Something like that, like
Yeah.
that's what you mean when you say hygiene.
Exactly.
Yeah, okay.
Yeah.
That's a good idea.
So that's, yeah, so Coolidge Corner Library, Brookline Village Library are the two locations that we've tentatively selected. We are asking for the select board support in that tomorrow night. We are prepared to pivot if we need to other locations. The last fallback would be the public health building. And it's in sort of the same general area, at least for Brookline Village, but
But it's not where people hang out.
I was gonna
People
say,
don't
like,
hang out.
people don't hang out.
right.
But in
So
your
I'm
new
hopeful.
courtyard,
Yeah,
Yeah.
let it come off of Harvard Street, maybe it'll
Right.
change.
maybe.
This is a great idea.
I think it's
And I can go on forever, so I'll be really quick. So Somerville's piloting right now, I already said that, so they have one at their library, one at their food pantry. And they're prepared through the pilot program to adjust products and locations depending on what the feedback and the data they get. So a lot of this has been modeled off of their program, which has been modeled off of, I think, the North Adams program, which was one of the first. ABCD in Boston also has vending machines at their neighborhood service centers. That pilot is focused on sexual health outcomes more than broader public health outcomes, but it is yet another example of a program that's using the test and go kiosks.
Are they doing naloxone there too or not?
I don't know for sure. And this, I'll just leave this up and then we can get into questions. I just wanted to thank those who've been a part of this project. So Darlene has been the driving force right along. Layla McGeorge, who runs our Be Well Coalition. Kat, who's our public health nurse, is a great thought partner. Abby Dean runs the behavioral health improvement program for the high school. And then I get a small, tiny portion of credit. I would love if Darlene could have been here, but she was under the weather. So I said, I'm happy to take this on tonight for you. So. And with that, I'm open to feedback, questions, thoughts.
Said you're gonna ask date of birth to try to.
Yeah.
Just wonder whether or not you should just ask the zip code. Just ask people to put their zip code in, just so you get.
Yeah.
Because again, if someone's from out of town and visiting, they'll punch in presumably where they reside otherwise, just so you can come back to the town and see like how many residents in theory served.
And there are different models, and I don't know if this was the test and go kiosk or another one that Darlene and I looked at, but there is the opportunity to pre-register people and give them like a physical card, but that creates a barrier, which is what we're trying to avoid. And from a data scientist perspective, I'd love to have all that data, but for everything that we do here, we try to reduce those barriers as much as possible. And so I'd rather just get it out there and get less data and make this much more accessible. So that's kind of the plan. But if we can add zip code, that's not a bad
That's not personal identifying.
Right.
In
Right
terms,
here.
in terms of health outcomes, I mean, you've said before, we don't get data from the state about opioid mortality or anything like that.
I mean, the state tracks it through, the healthcare data that they get, and we have engaged with Coastal to try to get some of at least the overdose that they go out on calls
So that
for.
would be interesting to see if we could look at overdose.
Yeah.
That changes over time.
Yeah. And,
Good idea.
and also, if you've got condoms and other things, we could look at STD rates.
I don't know if things change that quickly.
Yeah, I don't think so either.
Yeah.
But
I think it's a great idea, but I'm not sure that we could, I think the landscape of the drugs are changing a little bit, and I think that there's a little less fentanyl, and so there's a little bit less overdose, but maybe not because people's behaviors are changing.
mortality rates are going down substantially.
There's a lot more naloxone out there too. The
There's
state has done a lot of work trying to get it, and so I think it's everything.
It's
right?
everything, so I'm not sure that we could
No, we couldn't point it, right.
point at this, but this
Post
is a
hoc
great,
contra-
I think, even just saying what do people want to use, it would be useful to know. That would be data that would be easy to collect because see what's being depleted. I think it's terrific, and if you had some kind of focus group, you could find out what do you wish was in there and that you didn't find in there. But what a terrific thing. I think we should all say yes, we support it. And how do others?
Oh, I think we
Yeah,
actually,
sure.
it's a great idea. So, So I checked with one of the select board members to see if there would be controversy. All that person said was, we should, if we care, we should all show up. So I might urge people tomorrow night. Is it still scheduled at 7:30 on the agenda?
Around, yeah, there's something before me at 7 o'clock, so I think that's what they're projecting, but these things are all very fluid and depends on how the.
You can participate by Zoom in select board meetings.
Is there a time for public comment at that point, or is it at the beginning?
I think just at the beginning.
Yeah.
Yeah.
Well, it's actually,
I shouldn't say that, I don't go to enough select board meetings yet to know there is a public comment portion.
there is a public comment. Usually what they say is the public comment portions for items that are not on the agenda and that public, but I also don't know if it's considered a public hearing or not.
I don't think so.
So
I mean, I
if
am
it's not a
asking them
public
for
hearing, that
support,
means
but-
we would speak at the start.
Yeah.
So, anyhow, just showing up also sometimes helps just if they see that they're. So I'm gonna try to sign.
Can they label some of the dispense materials with like a QR code, for example, so if it's naloxone, here, you can, just again, a message of where you can scan to try to get resources for drug abuse and prevention, or if it's essentially, the kid, like again, if you suspect you might have a sexually transmitted disease, here's a public health resource to pursue. Again, just something to go along with the actual device or so. It could be stuck on as a sticker.
I'll ask.
I don't know.
I know we have control over what's going in there, so theoretically, we should be able to provide them with the stickers, and get them on there. We certainly can do that messaging on the outside of the machines, but I agree with you, if we can get it on the actual,
On the kit itself,
The
or
kit
whatever
itself
the
is
dispense
best.
material is that's
Yeah.
relevant to that issue, that risk, that someone's trying to mitigate.
And there's no plan B here, right?
no, not at this time, but
It's an interesting thought.
there's been lots of interesting thoughts along the way, and I think we've tried to be
Sure,
strategic
was
to
the
start.
easiest,
Yeah.
but that would be on my short list after.
I agree. All right, well, terrific. Again, if you have the chance, I think tomorrow would be great to be in the select board meeting. Certainly convey our unanimous support for it.
Yeah, should we take do you wanna take an official
Why don't
vote?
we take an
Yeah.
official vote?
Okay.
Anyone want to make a motion?
I make the motion to, support,
Yeah.
Support and encourage data collection.
yes.
Second.
Oh,
We all unanimous.
Yep, unanimous.
And it didn't say, and I don't think it would have changed your votes, the chief of police did submit a letter of support as part of the select board package, that I submitted last week, so that I was appreciative of that. Yeah. So on to select board. Thank you for the test run tonight. Hopefully I'll see some of you tomorrow, and
Oh my gosh, it's like tonight's.
I love this.
You love
This
these
is
kinds of-
great, this is the fun stuff.
This is the fun stuff.
Okay, speaking of fun stuff, policy updates.
Yes, so we don't have anything to look at tonight, but I do have an update for everyone. So we have, I think, right now, 4 outstanding potential public health regulations. We have keeping of animals, which you all saw many months ago. We have feedback from town council on that, so I have promised that I would review that with Roland over the next week so that we can get that back to them and finalize that. And then we have updates to the model tobacco control regulation, synthetic cannabinoids, and kratom. And so, and I said this to Charlie when we chatted on Friday, I said I have not done a good job staying on top of town council and making sure I'm on their radar, and I don't even know yet as the new director who's the best person to send what, because there's multiple staff over there. But good news is I have talked to several staff over there. They are reviewing them actively as we speak. I said, can we please do this? I'd like to do kratom first, synthetic cannabinoids, and then tobacco control, because I think that is the order of easiest to hardest. And they were fine with that. And so I think that's the order you will start to see them come back to you over the next couple of months. Tobacco control being the last because I think what I don't know yet, I suspect what's gonna happen is we will leave the bylaw as is, and what we'll do is build around it with regulation. So where the model regulation has been updated, we can either present it at town meeting and say, will you vote on this? It's not my preference, but we can go that route, or I can just start building out pieces, like addendums to the model regulation, as changes happen at the state level. So that's the plan right now, but I wanted to talk to town council and.
Addendum to the model regulation or addendums to the bylaw?
Addendums to the bylaw through regulation.
Yeah.
The other option is to ask town meeting to rescind the bylaw and at the same time just submit the regulation as public health regulation. I just think might be too complicated for some folks. I'm happy to do whatever works for everybody else. I just want to update the regulations so we're staying up to date with how the model regulation is changing. And bylaw makes that harder because we have to wait for town meeting and then.
Yeah, things that would challenge, unlike the federal Congress, I'd say town meeting is probably protected with its prerogative, so. My guess is if they feel like we're taking something away from them, that could cause trouble. So your approach might be.
Yeah, so more to come on that. And then we do have a couple of warrant article updates. One for tonight, one I guess, warrant article updates is up there. Warrant article 17 was the no firearms in certain areas.
Yeah.
That Anthony Ishak had been a co-sponsor of. So AG's office has signed off on it. So that is now local bylaw, and then the faux gras ban is also now local bylaw, and that has been implemented.
We've already had a report.
We've already had a report and we've already had a conversation.
So we have to amend that.
There's not yet.
We did.
Okay.
Just realized we've gone beyond the presentation. There we go, just so everybody can see us. Yes, so we had an inspector go out. We got some questions from that business. We answered those questions today, and so I'm hopeful that we'll be able to move forward with them.
So what happens is another inspection, like
Another
an
inspection,
abandoned
yeah.
inspection in the next month sometime to see if.
And they've been communicative, so I expect that they're gonna come into compliance, so.
I was struck on the other one, the one
Yeah.
on firearms. The careful wording of the Attorney General.
Fascinating.
Which was pretty much, yes, this doesn't violate the state, but you better talk to town council and make sure this is consistent with the recent Supreme Court decisions. And then they cited a couple ones that seemed to indicate it's okay with them.
And they said, we don't support so don't take this as support, we
Right,
just are
no,
saying
I-
it's not
I-
illegal.
Well, I mean, that's fine. I mean, that part I thought was okay. Because, yeah, it's up to the town, but I was surprised. I would have thought the Attorney General would be more helpful in terms of whether this is consistent with the federal constitution. So do you?
I don't know anything else more yet. I have not talked to town council about this one. I did read that as well, though. I found that interesting. Some of it's boilerplate, like we don't take a position on
Yeah,
this,
that's
we're
what
just
I
here
thought,
to
that was
rule on the
boilerplate.
legality.
But the part about, I mean, yeah, I thought that was for the AJ's rule, and say this does seem consistent. Interesting.
Lexington, Concord, not Brookline.
Right.
1776.
All right, good. Yeah, well, Rich, and then the reports, anything which you would like to highlight?
I've done a lot of talking tonight. I will say you all saw a draft of this, or you saw a December version, and what we did, given the holidays, I just asked staff, I said, if you have updates in addition to, and so we made some revisions, and that's what you see is kind of a combination of the December report and the January report.
Like this New Year, New You, same months thing that that person put together, that was very cute. Smoking baby. And, you know, and 81% of high school students have vape. I'm not very demographic, but it seems convincing. How with the flu stuff, is that kind of overwhelming? Folks, or yeah, we're just saying, yeah, a lot of people have the flu.
We've definitely gotten a few, I've gotten a couple emails. I don't know if there's been any calls that have come in on the flu.
Not yet.
About flu.
Yeah.
What should we be doing?
Maybe some calls about vaccines, but not in the last couple weeks.
Counts are up.
Yeah, certainly the counts are up. We're keeping an eye on it. But there's, for us, it's
Yeah, you're not.
trying to vaccinate anyone who hasn't, like kind of last minute vaccines, which we're always happy to do. If we have any left in stock, we'd love to give out those vaccines.
Okay. This was a very rich, a lot of good stuff. So, really pleased. Thank you. Oh, anything new on where are we with the JIC? Have you?
Yeah, so there wasn't a huge update on there. So we are internally looking at dates. What we're gonna do is map out the entire year as far as getting the working groups and advisory together. So we're working on our internal dates that we can then present out to the steering committee, and then we'll have quarterly meetings this year and moving forward, which we did not consistently do last year. But as far as like implementation of the CHIP goes, we're
Right, in terms of,
We're
for
on.
example, getting the working groups appointed.
that will happen within the next few weeks. We've already gotten a ton of recommendations, so there's a lot of, and we've had a lot of great partners along the way who I
Yes.
think will want to be involved, so. Yeah, we're looking forward to democratizing some of the work and getting some of that input from outside of our agency, so.
Have a motion to adjourn? Great, so
Moved. Right. What are the dates for these meetings?
third Monday.
Third Monday.
Except next month.
Except this month
Second,
was ready. So this month. can be just-
I can email out the